Good afternoon, everyone. So this was one of my toughest cases I've done during my training period. So this was a 30-year-old male who presented with open globe injury following a blunt trauma. B-scan showed double membrane signs showing giant retinal tear with retinal detachment. So planned for a pars plana lensectomy and vitrectomy. Challenges were the patient had open globe injury, so poor visibility, higher rates of PVR. Tackling with the GRT with PFCL was the main game plan. And I obviously counseled the patient about poor visual acuity. I started by making an AC maintainer in the inferior quadrant. IFEMA was drained and pars plana lensectomy was done by 25G vitrectomy system. So intraoperatively, I had a major surprise. So there was about 4 clock hours of choroidal avulsion, which we could see as bare sclera was visualized. And the patient had 360-degree retinal detachment with close funnel retinal detachment with 360-degree GRT. So I took a moment and I thought I'll approach step by step. So the first I approached by opening up of the funnel. So once I opened the funnel, there was a lot of hemorrhage. Once I cleared it, I used PFO at the posterior pole just to make the retina visible. And Teno scraper was used to unroll the retinal flaps under the PFO. There were multiple membranes in the periphery which would be dissected with the Teno scraper. And under higher magnification lens, I removed the posterior remnant hyaloid. So after a lot of effort, I could see the retina. I carefully filled the PFO till the edge of the avulsed choroid just to avoid suprachoroidal migration. And I used a Teno scraper just to remove the remnant hyaloid, and I did the 360-degree laser of GRT margin with. And following which, the second challenge was of the choroidal avulsion. So I thought I could just suture the choroid to the sclera just to avoid the suprachoroidal migration. So at 2.5 mm from the limbus, I used a long 26 gauge needle, and the polypropylene suture was threaded from the opposite side. It was a wide suture just to hold the choroid onto the sclera. I used a single suture. On retrospect, I thought multiple sutures would have been a better option. So there was intraoperative visualization of apposition of sclera to the choroid. So I did PFCL silicon oil exchange. And so what did I learn from this case? Suturing of choroid avoided suprachoroidal migration, postoperative hypotony, and maintained the vitreous volume. So AC maintainer should have been retained till the late stages to avoid the bubbling of PFO. Workplace personal protective equipment should be indispensable. So at 3 months, patient had 3/60 visual acuity. No postoperative hypotony or posterior slippage of choroid was noted. Patient was happy with the scleral contact lens, although did not improve much. Thank you.
Excellent timekeeping, and I must commend your mentors to give you this case as a very start of your VR career. Indian surgeons are very generous, clearly. So, so tell us, what was your role in this case?
So I did the surgery. I followed up the patient till the last follow-up.
Okay, so entire surgery was done by me.
Yeah.
Okay, right. Okay, judges, does anyone have a question? Panos? And then,
congratulations. Was this really your first case ever in your fellowship?
No, it was after 2 years of my fellowship. I have done 2 years of vitrectomy surgeries.
You had done many
I was in the second year of my training, yeah.
All right. So question is, would it be possible not to suture?
Sir, there's some literature about choroidal avulsion. There's limited literature. So those who are not sutured, there is tendency of choroid to slip towards the posterior pole. That will result in hypotony, and cases have been reported going into thysis bulbi also. So my main aim was to maintain the vitreous volume and reduce postoperative hypotony, which would allow the silicon oil to tamponade the retina.
And any risks when you suture choroid to the sclera?
Theoretically, there's risk of bleeding when we take the bites through the choroid, because since choroid is such a vascular tissue. but I didn't face such a challenge while suturing the choroid.
Okay, so I think Yannick had a question as well.
Yeah, my question was, how long did it take to have a post-operative PVR?
Sir, I followed up him till 3 months. He did start to have PVR at that point, but the patient was not compliant for the follow-up that much, but till 3 months of follow-up, the patient did have some PVR in the periphery. Just let it be there.
Excellent. So in India, they don't get PVR, Yannick?
Yeah, if you don't get PVR on this case, I stop surgery, you know? That's...
Okay.
Just a couple of questions. How long did it take before you did the second surgery after the original closure? And did you take any care with pressure, intraocular pressure, while suturing the choroid?
So both the surgeries were done by me. First, it was a step surgery. The open globe repair was done 3 days after the presentation, and the vitrectomy was done 7 days after the open globe injury repair. So the precaution I did take during the suturing of choroid was just momentarily raised when I was raised the IOP, when I was taking the bite through the choroid. Other than that, there was no special precautions. Yes, rather than going through the scleral route, I should have gone through the clear corneal route. That would be easier for me. Other than that, no other precautions were anticipated.
Anyone else? Questions? Excellent. Thank you very much.